So I will move on to introducing our next panel. It's my pleasure to introduce Dr. Priya Sarengupta, who's the Senior Medical Director in the Office of the Chief Medical Officer at Mass Brigham. And she's going to be both a moderator and panelist for the next session, and I will let her introduce her crew. Come on up, guys, and please give them a round of applause.
Good morning, everyone. My name is Dr. Priya Sarengupta. As mentioned, I'm the Senior Medical Director of Clinical Community Programs and Medical Director of Mobile Health Services at the Kraft Center for Community Health at Mass General Brigham. In January 2018, the Kraft Center partnered with Boston Healthcare for the Homeless and the Boston Health Commission's A-HOPE team to launch the Community Care and Reach, a mobile addiction services vehicle designed to bring both clinical care and harm reduction services directly to the individuals at high risk of overdose, particularly those who were disengaged from traditional care. The project came about because data showed that despite Boston being resource-rich, when it comes to healthcare, many were still falling through the cracks. By mobilizing care, the intent was to create an entry point to care for individuals who could address many aspects of their care needs in one convenient spot. Initial results were stark. Not only was there a clear demand for these services, but 55% of patients seen in the first 11 months were new to Boston Healthcare for the Homeless program's electronic health records, indicated that the van was indeed reaching people who were not accessing traditional care. Since 2018, the model has been replicated across the Commonwealth with funding support from the Massachusetts Department of Public Health Bureau of Substance Addiction Services. Since 2024, the Kraft Center has hosted annual virtual conferences on mobilizing addiction services to support taking clinical addiction care and harm reduction services outside the walls of the brick and mortar clinics. We are thrilled to continue this effort at today's conference with this esteemed panel of leaders and pioneers in mobile addiction services, serving communities from all over Massachusetts. I'm going to start with our first question, and each of our panelists will take a moment to introduce themselves before answering the first question. So the first question for the panel, and we'll start with Allison, is how has mobile health expanded access to addiction services at your program in ways that brick and mortar facilities cannot?
Sure. Thank you. Good morning. My name is Allison Pinkover. I'm the Director of Substance Use Services at Brockton Neighborhood Health Center. Our mobile program is one of the programs within our department that I work closely with the team on. And I think one of the things we've learned through mobile services is that we really reach a population of people who are not coming into the brick and mortar site. I think, in the beginning of mobile services, there was this aspiration that if you could get started, people started on buprenorphine via a mobile program, you could transition them to a brick and mortar clinic. And I think we've found that that works for a very small subset of people. That's not actually the goal, and doesn't actually work as well as just keeping people engaged through the mobile program. So I think the biggest takeaway we've had is that we're really reaching people where we're their only point of contact for medical services in the community. And I think those are exactly the kind of people we want to be reaching with mobile services.
Good morning. My name is Jillian Joseph. I'm the director for Road to Care, which is the mobile program in Worcester, Massachusetts, affiliated with UMass Memorial Health. And I agree, Worcester has a pretty robust healthcare for the homeless service, and they have their own office, and it's affiliated with the Family Health Center in Worcester, but there are still so many folks who just can't get there, even though it's a relatively convenient location and they know the providers there. Just being where the people are makes such a huge difference in building those relationships and maintaining continuity that they wouldn't otherwise be able to access.
Good morning, everyone. My name is Jessie Gata. I'm a little hoarse from yelling at a sport event recently, but I am an addiction medicine specialist and internist at Boston Healthcare for the Homeless Program. I've been working on our mobile van for the past 8 years since the beginning, and I'm really glad to be here. So amazing to sit back and meet people from across the state doing similar work. Also really grateful to the support that we've had to get this off the ground from the beginning, from the Kraft Center for Community Health and also from the state Department of Public Health. But the question is about access and how this changes access. And I think I would say that in the beginning we started with some data from our local EMS showing where street and business overdoses, fatalities were happening. And we noticed that they crossed every single neighborhood in Boston, and that even though, in most of those neighborhoods, there was some access to harm reduction services, life-saving services, as well as addiction treatment services. Not all of the neighborhoods was that the case. And suffice it to say that for the past 8 years, we've really been kind of going street by street, alleyway by alleyway, trying to connect with people who just are not coming into care. There's a lot of access in Boston, and it's still not enough. And so I guess what I would say we've found is, like Dr. Gupta said, we're seeing patients that who are experiencing homelessness do not use any of the health systems in the Boston area for lots of reasonable reasons. And I think were it not for us bringing care directly to the street, really would not be engaged in these services. In fact, I think when we first started, we thought this will be a bridge to bring people into care in the health centers and in the hospital clinics that have state-of-the-art care to deliver. And that really hasn't panned out as we hoped. It really is the case for a small number of people that we can successfully get them into addiction medicine specialty clinics at the hospitals or into community health centers. It is mostly the case that the care that we're delivering is the only care that people are accessing. So I guess I would leave it at that.
Good morning, everyone. My name is Monique Horton. I am the senior recovery coach at Mass General Hospital. I work in the emergency department. I work in a bridge clinic, and I also work on a mobile van. And I think I can speak from both accesses. I can speak from my personal experience and working in the community. The mobile van was the best thing that happened when I found out that this is something that we was gonna do, because we get to go and we get to see what's really happening out there, especially in the Black and brown community where treatment wasn't being reached. And so it has been an amazing journey to be out here doing this work and bringing education and getting people to buy into getting help for getting treatment.
Thank you. And I'll just add, I work closely with Monique on our mobile service line. I think by bringing the care out into the community, really moving the front door of our clinics into the community, we're often engaging people that we'll have people come up to our vans because they're hungry and they're looking for food, and then we're able to engage them in their health care. So we're often in a position where we're able to address what their first need is or what's top of mind for them, and then really get them engaged on a pathway to better health. So I'll move on to our second question. So while presenting unique opportunities, mobile services also face unique challenges. Please describe some of those challenges and how does your team overcome them? And we can actually just go down the same line if that's okay.
I think my answer to this question has changed over time. I think that definitely from an administrative perspective, I think we all could tell you about how difficult it is to find enough physical space to park a mobile unit, and is someone going to give me permission to park there? And those are all manageable challenges. They're different than, I think, the things we think about in a brick and mortar setting. these days, I think, as we've mentioned, I'm actually much more worried about what's going on in some of the like local and municipal government around restrictions around harm reduction services, or how folks who are unhoused are being treated. And, you know, I look throughout the country and become really worried when I see municipalities who are trying to put restrictions in place on things like mobile services, on street outreach, like the things that people are allowed to do as a part of those services. That is like one of my biggest fears right now. It's like always kind of looking over my shoulder, like, is that coming? I'm not sure, because it feels like it is. And so I think right now, for me, the administrative challenges are manageable. The policy changes worry me more.
Agree. I would say also from a more logistic perspective, where we are providing primary care and sort of are the, you know, last resort for primary care for so many of these folks, the challenges that go along with being a small team and not having a ton of administrative or back-end support to do the things that, you know, as a clinician, I don't always think about, like, how do I get someone scheduled for an MRI or an advanced imaging test, or how do I get them to actually get an appointment at the specialty office, things that, you know, the ancillary or support staff handles in my traditional brick and mortar primary care. So those are some of the nuanced things that we've been trying to sort out. And UMass is a pretty large organization that is not always the prime example of organization, as I think most large organizations can tend to be. So sort of figuring out the pathways to get those things done can be really challenging.
Trying to narrow it down to just a couple challenges that we face and that we're working to overcome. But maybe I'll start with one, which is, you know, with the goal of kind of making it easier than, or as easy as it is to purchase a substance on the street corner. I want it to be just as easy to have access to naloxone, safer use supplies, and evidence-based treatments for addiction. So it's one thing to bring our team to that street corner and be able to have the conversations and move forward so many of those services, but we can't bring the pharmacy to the street corner. We can't bring the insurance company or the insurer to the street corner to get that person enrolled. So sometimes there are challenges making the whole system accessible on the street corner. And we overcome those in a lot of ways. Like, for instance, you know, we have a kind of beeline to Mass Health to help people enroll or re-enroll if they're eligible for that service, like right there in the moment, because we know we have to kind of capitalize as much as we can on that moment with this individual to get as much as we can done in that moment. So we'll make that phone call. That's often a 30-minute ordeal. We may get to the point of writing a prescription for buprenorphine, for example, and then it's the case sometimes that we need to go to the pharmacy with that person who is going to face some kind of obstruction there around having their ID, and so we'll take care of that for them, or whatever the case may be. So I think one of the challenges is that we're one part of a system that is trying to bring addiction services to the street corner, but we're a small part of the system, and so we have to work really hard to overcome the obstacles that exist. A lot of times it's just people don't have a phone, so figuring out how to get them a phone, bringing a phone with us, making the phone calls together, going to the pharmacy window as a team. It's a really interesting experience to write the prescription, walk with the patient to the pharmacy, have a prescriber show up at the pharmacy window, get to know the pharmacist, because that's the only way. Sometimes that's the only way you know that this prescription is going to happen and that the patient that you're serving is going to receive this medication. But so that's one set of challenges I would mention, that there are strategies to manage. And then I just would reiterate maybe what Allison discussed, which is with the shift in public opinion, with the shift in policies on a local level as well as nationally, away from harm reduction and away from evidence-based treatments for substance use disorders. What that means on the street really is that people are more hidden. I think when we criminalize homelessness, when we criminalize drug use, people become more hidden. When there are sweeps, people become more hidden. So whereas, I've been parking the van for the last 8 years on one particular quiet street corner in Nubian Square and seeing a lot of people who need this care, who need this service, with a shift locally away from people being allowed to exist in public spaces and use substances, I'm finding that that location doesn't work anymore, that people are way more hidden. They are trying to avoid law enforcement. They're trying to avoid intersection with anything that might get them caught up with law enforcement. So that's a big challenge. And I guess question of like, how are we overcoming that right now, all of us? I think we could talk for a long time about what we're trying to do, but it means a lot more foot outreach, building relationships so that people tell us, here's a place you need to go where there are a number of people who need this care, but you can't blow up their spot. You need to do that really quietly. You can't go in with a big vehicle, for instance. So there are a lot of very street-level strategies for still finding and connecting people, even when they're really trying to hide from most systems. Yeah, so those are some of the challenges I would mention.
Yeah, I see it a little different because I have the background and experience because I was out there. I was one of the people that was out there on the street. And one of the challenges, because I'm boots on the ground, like getting the community, especially the Black and Brown community, to understand that we are here to help and provide services, provide care. And so one of the challenges is getting us to trust and breaking down some of the stigma, like letting them know it's okay to come on the van and it's okay to talk to, because of the trust that we have, because we haven't had the care. And now that we're getting the care, we're still wondering, like, who are these people? You know what I'm saying? So I think it's a lot of trust, but I think we're doing a great job at just being consistent.
On that note, that this is so critical. That's like building trust among a group of people who, are kind of skeptical about who this team is, why you're there, who are worried about being caught up in a criminalization effort right now. I mean, some of the strategies you're hearing are, first, we're trying to meet some material goods, bring material goods that people really need. We're trying to come with consistent team members who are showing up every single week. We're trying to have people who are from the communities we're serving be a part of these teams, obviously, to help leverage the relationships that people have in these communities. And I think consistently showing up is probably the biggest thing. No matter what kind of chaos someone might be involved in is probably one of the most important factors, that you're there every single week, that it's predictable, and that you have familiar faces every week and not a whole new set of volunteers or interns or whatever every week is really critical.
And I would add to that too, having the right amount of time for the staff and for everybody to be out on the mobile unit is really important. We at first had thought, oh, we'll go out for 90 minutes or 2 hours and that will be enough, and it's not enough. And so then trying to figure out how to balance, none of our staff is full-time with the mobile unit either. We all have different responsibilities, and so making sure that we are present when we're present, but also kind of being a little bit creative about how we can structure the schedule so that we can maximize the time that we are out is definitely a challenge. But having lots of really invested, engaged, dedicated staff makes such a huge difference.
And I would like to add something also. Another challenge is not having all the access to the services that are needed in the community, like insecurities with the food and housing and things like that. That's very challenging. Mental health services. So that's the challenges that we're experiencing.
Before you move on from challenges, I think we have to say, because we've talked about it as a group statewide so many times, that one challenge we have right now is from a regulatory standpoint, it's a challenge for us to bring injectable forms of buprenorphine and administer them from our mobile units, which is something is desperately needed. I think we all can probably name several clients, patients, people who we're seeing who want injectable buprenorphine and cannot connect to the brick and mortar sites where it's actually available. And so we've been talking as a group about how to overcome some of the regulatory struggles that include, for instance, potentially approaching our regional DEA office to talk about how this would be possible for us to bring injectable buprenorphine. I think that is just such an important thing that we need to figure out next, and it's a challenge.
Thank you. So just going back to the trust piece again, wanted to hear what role has your mobile team played in building trust in your community? So we could start with Allison.
Sure, yeah. I think one thing, I think we say this all, never underestimate the power of snacks. Right?
And Crystal Light.
Yeah, Gatorade, we have fans of Gatorade in Brockton. But I think there's a lot to say for having staff who understand that building trust is something that's incremental. Like, we go out there, we have our own agenda, right? Or we're just like, hey, we have all these cool harm reduction supplies. Hey, we can give you medical care. And people are really far from being ready for that conversation a lot of the time. So, you have to be ready to put that agenda completely aside and just slowly over time show that you're in the same spot every week. That, even if you're just coming for a bottle of water, for something that's like a snack, you can come as many times as you want just for that. And that relationship building gets to a place where people feel comfortable asking more questions, saying, okay, maybe I'll come in and see you, right? And I think that just having the ability to show up and not push your agenda as a healthcare provider or a peer or whatever your feeling may be about it for the folks who are outside is something that's really important.
I would say we are so lucky to have our foundational team have two of the most amazing physicians who have been providing care to this population for a long time, and so we rode on their coattails 100%. And we were just like, yes, we're with Dr. Garcia, yes, and that really opened a lot of doors, I think, for us. Because he's already sort of a known and trusted entity in the community, and that really worked well. And overlapping a little bit with the healthcare for the homeless staff in different locations and times too, just helped to put us all kind of in the same light in terms of what we can offer and what our services are. And so that was really super helpful. And snacks, and more snacks.
Yeah, so what I find is helpful, because I grew up in the community, and I was someone that used in the community, and what's helpful was seeing someone that looked like me, so that they can see that if I trust these services, that maybe it'll work for them too. So I just like people that look like them, like me. I have understanding about what's going on.
Thank you. And then
But one sec. I was just thinking, with building trust, so we've been talking about building trust with people who are at risk of overdose, which is kind of primarily who we're really trying to help. But I want to just talk for a second about building trust with the rest of the community, which is really critical when you're outside of a brick and mortar site that your program often owns and operates and has been in for a really long time, where you don't necessarily need to get permission, so to speak, and to build buy-in from the public at large. But when you're out in a community, you need a place to park. You need there to be some political will that will enable the work that you're doing. You have to also build some trust, and you have to work hard at engaging other stakeholders in order to make this possible. I think that's just something else to point out about mobile programming of any sort, especially addiction programming, which is so stigmatized. So there's a lot of strategies for community engagement for mobile programs that have to start before the wheels even hit the ground.
And that takes months and months. We tried to expand for, I would say, 4 or 5 months to a new site before we were able to actually get there and be there. And then that takes even longer to build up the momentum of continuing to be there. So that's a big part of it.
I know that our program manager for the mobile program, Kelly's sitting over there, and I can't tell you how many batches of chocolate chip cookies she's made the Brockton Parking Authority over the years. So still snacks, also great relationship builder with the community as well.
Thank you. And then building on that, how has your community outreach been enhanced by mobile programming?
I think we make it to a lot of other places, which is fantastic, right? Like Brockton is geographically, like, it feels large to me. And, you know, our brick and mortar site is just one spot in downtown, but there's several like very large parks that are in Brockton. And unless you're making a concerted effort to go out and meet people where they're staying, right, they're not getting medical care. And so I think it's really enhanced our ability to just connect with patients who are probably already our primary care patients, right? Mass Health is saying that they're our primary care patients, right? And we just had to be a little bit more creative about how we lower the barrier for accessing care, right? I think a lot about mobile services as a way to shift the power differential in medical services, where if you're gonna come to brick and mortar, you need an appointment, and you know, you have to wait to see the provider, and you need your insurance to be active, right? Like there's not a lot of autonomy that goes on in that situation, but mobile services, I think, is able to just eliminate a lot of those barriers, where it's just like this is here for you, come when you want, and I think that has really influenced our ability to reach more of the patients, like I said, who probably Mass Health would say are our primary care patients anyway.
I see we have a 5-minute, or probably now 2-minute warning. And so in terms of outreach, though, I guess I would say, how does mobile programming, how might it expand our collective outreach? I think, so, there's outreach that's street-based, and we've, for almost 40 years, we've had street outreach teams across Boston. What's a little bit different about being able to bring a vehicle that's really outfitted and designed for this work is that you can bring all the things that you also need to accomplish so much. I mean, we draw blood, we use a POCUS to do a lot of clinical work. We have computers, printers, label printers for specimens. We have a lot of material goods that we can bring out into the community. We have vaccines. We have an entire clinic on wheels, but so really you can bring and do so much more in each individual encounter when you have all of these things with you, which feels very different to me than typical street outreach. But I think for programs that aren't even doing any street outreach, this really expands your visibility in a community, and it's going to reach more people than you otherwise would see. But it's not about the vehicle so much as it is about the team members, which is one other thing that I want to just point out. The magic really is in the team members.
Awesome. So to close out, and maybe in one sentence, and we can start from there, what advice would you offer someone looking to start their own mobile addiction service program?
Kelly and I give the same advice, I think, every single time, and she probably knows what I'm going to say. We're both a little bit type A, and and you really have to be able to lean into going with the flow, because a lot of things can go wrong, and you can't let it derail your whole day. Like, I don't know, cleaning snow off of a mobile unit was not something I ever used to think about in my day-to-day job, and now we do. So just, you got to learn to just go with the flow.
Thank you, Jillian.
I think the advice I would say is that although it's difficult work, although it's challenging, it's nuanced, it's layered, it's worth it.
There are lots of us that have tried this and have iterated this over time, so come out with us. Reach out to the Kraft Center for Community Health. There's an amazing booklet of information of how to get started, what supplies, what the regulations are, what licensure looks like, what staffing could look like, what funding could look like. So reach out to the Kraft Center for Community Health, come out with any of us to see the work in action.
And I say patience. You have to have a lot of patience, and you have to be consistent.
Thank you. So we'll close with that and open it up for any questions.
I have a question, if we have time. My name's Abby Batchelder. I'm a clinical psychologist. I run the Behavioral Health Equity Program at BMC, and am the Chief of Psychology at BMC. And I'm really interested in meeting people where they're at for mental health care, and I know Monique said that was a challenge in mobile units. I'm wondering if anyone on the panel has any ideas about how to better bring mental health care to the people where they are, to the street, like street psychology, from any of your experiences.
Yeah, I could say that I personally took an advanced mental health course for primary care clinicians that's available through UMass. That's a shameless plug, but it was super helpful just to increase my own comfort level with a lot of psychological and psychiatric diagnoses and treatment. But also we were very creative with our budget, and we were able to actually have a psychologist who has been out with us, who is really an expert in trauma-informed care, and that's made a huge difference.
Thank you. And I'm so sorry, we're being told that we're at time, but happy to take other questions at the end.
Yeah. Thank you all.
Thank you.
All right, thank you so much to our plenary panelists and our speakers. We are now going to get ready to break out for a coffee break. So you can also find the coffee through. You actually can't go through there. You're going to exit right here and just go straight down the hall to Exhibit Hall C. There's coffee. There's still some morning pastries. Let's all return at 11:20 a.m. for our next plenary session led by Stephanie Patton. Thank you all.